You're listening to Medscape's In Discussion series on urinary tract infections, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Lenore Ackerman, Associate Professor of Urology and the Director of Research in the Division of Urogynecology and Reconstructive Pelvic Surgery at the University of California, Los Angeles. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Hello, I'm Dr. Lenore Ackerman, and welcome to the Medscape In Discussion podcast series on urinary tract infections. Today, we're focusing on urinary tract infections and sexual function. First, let me introduce my guest, Dr. Rachel Rubin. Dr. Rubin is a board-certified urologist and sexual medicine specialist. She is one of only a handful of physicians with fellowship training in sexual medicine for all genders. Dr. Rubin is a clinician, researcher, and a passionate educator. In addition to being the former education chair and current director at large for the International Society for the Study of Women's Sexual Health, ISWICH, she contributed to the guidelines on genitourinary syndrome of menopause by the American Urological Association and helped announce the removal of the FDA box label on hormone therapy products in November 2025. Welcome to the Medscape In Discussion Urinary Tract Infection podcast. Well, I have to say it is truly a pleasure to have you here today to talk with us about, I think, some of the most important issues that I've seen come from my patients in talking about urinary tract infections, which is really how UTIs and recurrent UTIs in particular shapes life, daily life, identity, and sexual function. So I'd love to just maybe start off there and hear from you a little bit about your experiences in talking with patients about how these things really impact them, and maybe some of those things that we as clinicians don't ask about on a daily basis that actually are really important to patients.
Oh, well, it's such an honor to be here with a legend in our field, someone I admire and look up to so much, and was a warrior with us in writing those guidelines on genitourinary syndrome of menopause, and one of the proudest and most accessed guidelines in urology history, which is really thrilling. We have a huge problem because everyone takes care of UTIs, whether you're in the ER, the urgent care, the primary care setting, the gynecology setting, the urology setting, and yet no one is really doing enough to prevent UTIs and to look at the etiology. Why are these UTIs happening? And so a lot of our advocacy is really centered around getting people, patients and clinicians to understand that UTIs are often happening due to hormonal dysregulation, if you will. So something has altered the hormone status, which then creates a dysbiosis in the microbiome of the bladder and the vagina. And that is going to increase your risk of UTIs. And this is very tied into sexual activity because, as our clinicians know, sex is a contact sport. And when you have a lot of friction in the outside world rubbing against the inside world, that creates more inflammation, more potential dysbiosis that can happen, and it really increases the risk for UTIs. And so most patients don't put together the fact that hormonal changes that could have even happened 30 years ago are actually why they don't have sex anymore. It's why they're getting urinary tract infections. And it's really important that we connect hormones and the risk of urinary tract infections because we have absolutely incredible generic therapies that are inexpensive that can save lives.
If you see a patient with UTIs, and even if they're a young woman, how are you thinking about some of these hormonal issues? So I know we have a lot of young women that are on hormonal birth control or other types of hormonal regulation, or you have patients that had breast cancer and are not normal in terms of their hormonal regulation. How do you think about that across the lifespan?
Yeah, I am thinking about the whole person. I'm thinking about their story, and I'm doing the basics of medical care is getting a good history of what is this person in front of me? What's the situation? It's not just throwing antibiotics for a quick 5-minute telehealth visit or a portal message because they have a UTI, but it's actually taking the time to say, you're on spironolactone. Spironolactone blocks testosterone. Your blocking of testosterone is causing a dysbiosis, which actually could be increasing your risk of urinary tract infections. Why don't we talk about that? Or birth control pills, for example, because birth control pills also create hormonal changes. Again, I'm not putting a good or bad, right or wrong, but we know that hormonal birth control blocks testosterone as well, which can also create a dysbiosis and cause a increase in urinary tract infections. We know breastfeeding or pumping also create the same problem, and the breast cancer therapies do this as as well. And so what I always say is when you play with hormones, there are consequences. Sometimes they're good ones, sometimes they're bad ones. But the more we deeply understand how sex hormones work in the body, the better we can really figure out what is going on with our patients. And vaginal hormones are miraculous medications that are safe for every human on earth to prevent UTIs. And that's really important. I think, again, when many of us went through our medical training, we didn't learn about the genitourinary syndrome of menopause. We didn't get the connection between hormones and UTIs. And we thought of this problem as vaginal dryness. Oh, use a little lubricant, you have a little vaginal dryness. That doesn't sound serious to me. But urosepsis and death, that sounds really serious to me. And it is serious, and it's costing our healthcare system very large amounts of money, and it's really hurting the people that we love and care about. And so us really saying like, "Oh, wow, we got to look at this a different way." So when someone does have a UTI, it's not just here's your antibiotics, but it's, how can we prevent this from happening? And it's not the old wives' tales of wipe from front to back and pee after sex. It's okay, drink a lot of water and actually use vaginal hormones to make sure we're supporting the tissue to make it as healthy as possible.
And I think that with women that are sexually active, even more so, UTIs can have a really huge impact more than just, the perturbation of the microbiome. There's a social connection that's important in relationships. There's a quality of life that comes with having a satisfactory, sexual relationship with your partner, whatever that means to you. And how do you feel like both UTI in general, or recurrent UTI particularly, and these hormonal changes impact on somebody's overall well-being, and their sexual quality of life?
I see it every day. I mean, I had a patient just yesterday who said, I got a UTI in February and I have not had sex with my partner because I am terrified, right? It's June and she is terrified of causing that same. She said it was the worst pain I've ever felt in my life. And so not only is she not having sex with her partner, but she's avoiding him completely. They're not holding hands, they're not kissing, they're not hugging, they're not connecting because she's afraid that he's then going to want sex and she is afraid of getting a UTI. And so it breaks down communication, it breaks down intimacy. It affects so many people, right? It affects the workplace. It affects how you parent. It affects how the grandmas take care of their grandchildren. Like it affects so many intimate connections. And we just throw antibiotics, which again is it's great to treat the infection if that's what it is, but antibiotics are not without consequences as well, as we know. And so we really need to look at this. It seems that the simple things are not being done. The more I learn about UTIs as a urologist, you think we should have had this figured out by now. But the more I find myself being like, are we doing this the right way? Because I don't think we are, right? Like, and again, as we are the top level specialists that people go to, but we need to be giving more resources to our primary care colleagues, to our urgent care colleagues, because you are on in the trenches. You are at the first line and so we have to that's why we wrote the guidelines, Dr. Ackerman and our group, is because we need you to know that you should and can be prescribing vaginal hormones from these locations. You do not need a urologist or a gynecologist to do it. You can do it through telehealth. You absolutely should be empowered to write these prescriptions. And that's, why we wrote the guidelines with a step-by-step guide.
Yeah, and I think that's one of the themes that I keep coming back to, that keeps kind of coming up in a lot of these discussions, is this idea of changing the focus from the management of the acute episode to both management of the whole person and a lot of their fear and their shame, surrounding UTIs, but also trying to prevent them from happening, because that fear and that shame is not happening just in those acute episodes. It's happening when they get those infections, and then they're dealing with the aftermath of that, the fear that it's going to come back, the ways in which it might impact their relationship, or however that's impacting their daily life. So in your experiences, I think you probably managed to get patients to tell you things that maybe other providers don't take the time to find out. So what are patients not telling their doctors about their experience with UTI?
Patients aren't telling you anything. Like, we hold space for these 10-minute visits. What on earth can I find out about a human in a 10-minute visit that really gets at the core of what's going on? I don't care how smart you are. I don't care how much you know the physiology, the pathophysiology, or how to write prescriptions. You do not connect with a human being on a deep level in 10 minutes. And so here's where medicine is totally broken, is we can't actually get to the underlying issues because we don't take enough time to look at the whole person and to help educate. Because if I get enough time which I've created my practice in a way that I do. But when you can actually educate people on why vaginal hormones prevent UTIs, then they use them. And guess what? They then don't get UTIs, and you get them comfortable and understanding of why it's safe to have intimacy, have sex. Sex is not painful and it's not a chore. And it's actually pleasurable. And they actually have orgasms and they actually have arousal and it feels fabulous. And so it is the time, right, that it does take, and it can be overwhelming, but it's also on the patient. If you're just going to urgent care for 5 minutes or doing a telehealth visit for 10 minutes, you're not going to get the full person picture. And there's not probably going to be one doctor that's your magician that fixes you completely. Like, you may have to build a medical team to support you. And if you are with someone who's not treating you well or taking you seriously, or actually connecting with you on a human level, you need to rethink what you're investing in your healthcare story. And it's a challenge because aren't that many, even doctors who aren't taking time with you don't have openings, right? Medical care is at its brink. Like, we are all swamped and have long wait lists. And so it becomes this challenge of, like, you go to 10 doctors and you're not getting actually the if you just spent, enough time with one person who could sort of look at the whole picture, you're going to do a lot better ultimately.
Absolutely. Let's say you have a patient who has been afraid and, comes to you, has been refraining from sexual activity. And let's broaden this out a little bit. It could be because of fear of UTIs. It could be because I hear patients tell me, well, use it or lose it. It's probably all closed up down there. I'm sure, that's misinformation we always have to combat. But you've got that patient, they're afraid and they're wondering about they're seeking guidance on how to resume sexual activity, on how to get back in the game, if you will. What do you tell them, or what are some of the things that you kind of go through with people when they're afraid, when they're looking to reestablish those connections and do it in a way that doesn't make them afraid?
So I think the important thing here is not everyone is the same and not everyone wants to have the same kind of sexual connection, and not everyone's education on this is exactly the same. And so I find, again, it is getting to know my patient, learning what they care about. What do they want? What are their goals? What do they actually want sex to look like? And this is not, do you have sex with men, women, or both? This is like, what is important to you? Is penetration important to you? Is clitoral stimulation important to you? Like, what does it actually look like? And unfortunately, doctors don't get much training in this. And so they can be more awkward than the patient sometimes. And they're not going to ask these questions. I've never been asked any of these questions before. And everyone knows what I do for a living. And so we're not asking, we're not connecting with our patients at that level. And so how can we possibly give good advice if we don't know what our patients actually want or care about? And so sometimes there's basic education of, here's where your clitoris is. Here's how the clitoris works. Here's how pleasure happens. Here's what arousal is, and is penetration important to you? Here's a mirror. Let's look at your genitals together. Look how raw and irritated and painful they are. Of course, sex is going to be painful. Just touching you with a Q-tip is causing you immense pain. Look at your pH. Your pH is 7.5. It should be 4.5. No wonder you're having so much pain and UTIs. Here's the treatment. Come back in 3 months and I'll show you how you magically made this all better, right? And I think it's that empowerment. The more we empower patients to learn about their own bodies and how they work, the more then they stick to the therapies and they show up to get better and better and better. And that's where it really is a village. So I try to get to patients, do you like books? Do you like podcasts? Do you like YouTube? And we try to put as much content out there in different ways, because your 10-minute visit sometimes isn't enough. So we've created a lot of resources around GSM on YouTube, on our website, because the clinician in 10 minutes doesn't always have the time to convince these patients that vaginal hormones are safe. So you send them to YouTube, you send them to our podcast, you send them to these things to say, hey, this actually is really worthwhile and you should care about this. And so it's a case by case basis. But what I will tell you, Dr. Ackerman, is that when you actually take the time to educate a person about how their body works and you explain it to them in terms that make sense to their own personal stories, we see miraculous things. We see patients who can reclaim their intimacy, who can find their orgasm after 15 years of it being gone, who can connect with partners old and new, who can like really feel pleasure and joy and intimacy again. And it's possible. I think we have this idea of like, once it's gone, it's never coming back. And that is just simply not the case.
Yeah, absolutely. I want to get to kind of a different theme that I hear a lot from patients, and it interplays with, I think, with sexual function in a lot of ways. And that when I see patients with recurrent UTI, there is often a lot of shame. And around that shame, you have a lot of behaviors that develop they're definitely not helping their UTIs, but they're also kind of destructive in relationships and destructive in their own sort of self-perception. This idea that they're getting UTIs because they're unclean or there's something wrong with them, or, maybe thinking sex is bad. There's all these tie-ins with, maybe behaviors that I have are what causing this, and it's somehow all my fault. And there's a lot of self-blame and a lot of shame that kind of surrounds this idea of, why is this happening to me? It must somehow be me. And I hate that. I think there may be some ways that we as clinicians, with the, well, you need to wipe front to back, also perpetuate that shame. And I think you're probably one of the people who feels the most passionate about making sure that people can have these sexual relationships without shame, whatever their goals are. How do you kind of address some of these issues, or sort of what are the things that you've heard from patients along these lines, and how do you kind of turn that so that they can stop blaming themselves and move towards more productive ways of managing what's a medical condition, not a personal problem?
Oh, I love what you just said there at the end, right? A medical condition. This is biology, but no one explained it to the patients. We forgot to explain it to patients, but guess what? Nobody explained it to the doctors. And so this is part of our problem and this is where we had to write the guidelines. We had to do it. We had to get it on paper. We had to put it all together. And it's such a beautiful document, but that is only the first step. And we have so much work to do to, market it, to tell people about it, to teach doctors about it, to get the word out, so that the frontline people can feel confident in saying this is biology and this is medical. This is serious medical business. This isn't just sex and pleasure and dryness. This is urosepsis prevention. And so this is the war that I am waging on people of, like, we have a lot of work to do to educate here. And so for the women, the women are just trying to feel better. They're trying to do whatever it is in their control to feel better. And part of that is sort of, okay, what am I doing wrong? And the truth is, you're doing nothing wrong. You are never were doing anything wrong. It was the biology the whole time. And I think that is what is so important when we talk about gaslighting. Women gaslight themselves every single day, right? And yes, they get gaslit by the outside world too, but that's where education and teaching biology, our patients can learn the biology. This is not complex biology. This is very simple biology. And it's very impactful because at all ages, you can disrupt your hormonal signaling, whether it's birth control pills, whether it's anorexia, whether it's, spironolactone or breastfeeding or menopause or perimenopause or PCOS, now called PMOS, all of that can create an environment where you are at risk for urinary tract infections. And so we have to look first and foremost at the biology and help the biology. We have very safe, very effective, very inexpensive therapies to help the biology here. But if no one's prescribing it, if no one's using it, then what the heck are we doing? And that's where my blood boils, because it's one thing, Dr. Ackerman, when we don't have solutions, right? Where it's like, oh man, we got a endometriosis. What is it? How do we treat it? What do we do for it? Like, that's a I get it. That's frustrating. But even more frustrating is that we actually have had data and solutions since the 1970s, right? It's now 2026, and our friends in at Stanford just published that less than 9% of patients are getting prescriptions here who need it. Less than 9% of patients. And so this is a 10 alarm fire, because I can't wait 30 years before women get prescriptions, because women are dying. Like, our loved ones are dying and having really impacted quality of life. And so I think it's really, really important that we educate on the biology and we take away, that's what takes away the shame. And so this is why, yes, I treat patients one-on-one and I love doing that, but this is why I'm so called to do podcasts and go out there. And I just yesterday spoke to a group of moms at my kids' school. We did a salon style thing. And for women to hear that they're not broken and that it's not their fault, and that there are explanations for why they don't feel like themselves as they're going through perimenopause and menopause, it's really empowering, actually. And this is why I'm so grateful for you doing these, for really brilliant people to get on microphones and say, like, there are things we can do.
Yeah, that's super important, and I think that there's been too long a tradition of blaming the patient for this as a condition, and I think also this concept that's very predominant that, like, oh, there must be something wrong with this patient. A lot of the referrals I see as a urologist, they come in and they're like, well, there must be some reason that they're getting all these UTIs. Something, they've got a kidney stone, or they've got, and everybody's grasping at these rarer causes of UTI when we have a very obvious cause that's right in front of them, but that no one feels comfortable dealing with. And I think we are on the heels of, decades of bad public information. I think from, the Women's Health Initiative, not that the Women's Health Initiative was bad, but just that a lot of how that information was presented to the public was really deceptive. And it's led to generations of doctors and patients believing in hormones as bad, believing that they're bad, that they shouldn't use them, that they can't have them, and that that's a terrible thing. So when you get that patient that comes into you and is like, and you go through the biology, you present this as a solution because it is that, how do you deal with their additional fear that everything they've seen or heard on, social media or in the news, all of those things that inspire fear about hormones? How do you sort of take that and unpack it for patients so that they can feel more comfortable?
Yeah, I made a New Year's resolution to myself a couple years ago, and it's working quite well. And it's meet people where they are and give them what they need. And something they don't teach us in med school very well, and you're very good at it, and I'm very good at it, but it's reading a room. It's being able to see the patient in front of me and figure out what is it, what are the roadblocks, and how do I use my knowledge, my data, and my emotional intelligence to really try to figure out how we can get to a place that I think that's worthwhile for you to get to. And I wouldn't say I hit it every time, but the truth is like there are barriers and there are misconceptions and there are false, sort of beliefs. And so I go back to the data. I go back to what I know to be true. There is more data that I have at my disposal to show that vaginal hormones prevent death in breast cancer patients than I have there's not one single study on earth to show mortality from vaginal hormones and breast cancer or any patient for that matter. So we have life-saving data and more is coming out very soon, which I'm excited to share with the world. And so the more life-saving data we have, so we all in our lives take risks and benefits. You get in a car, get on an airplane, we do all sorts of things. People smoke, people drink, people do also eat French fries. Like we do all sorts of risky things in our lives. And so it's getting to at the root cause of like, is your fear real or is it not based in reality? Like, what is your fear? And can I use my logic to help you think through that fear of if it's real? Because you have to paint the picture. What is the risk of not taking vaginal hormones? What is the risk of not doing this? And it is enormous. It's real. It's tangible. It's touchable. You lose your sexual health. You lose your orgasm. You lose your arousal. You increase your frequency, urgency. Your leakage gets worse. And you could get a UTI and die sooner than you should. So it's painting that picture of there is almost no risk that we know of, and it's been around for decades and decades, and the risk of not doing it is massive. And so that's where I kind of think about it, but you got to meet people where they are, and you have to take the time to figure out what they need.
Absolutely. That is a wonderful way, I think, to summarize where we are and to sum it all up. And so I just want to thank you so much for your time and for being here. Today, we've talked to Dr. Rachel Rubin about how urinary tract infections interacts with sexual health and well-being. And I mostly really want to re-emphasize how wonderful it is to focus this conversation on the biology and not on the patient and their failings. This isn't about that. We are really much more focused on impacting that biology, that underlying cause of UTIs through the use of vaginal estrogen. So thank you so much for that insight. It's been wonderful to speak with you. And thank you all for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on urinary tract infections. This is Dr. Lenore Ackerman for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Urinary Tract Infection podcast series with our host, Dr. Lenore Ackerman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on urinary tract infections.